Well, since we are talking about toric intraocular lens, the first thing that comes in mind is how to select, and I have no financial interest with the subject matter. Now, why toric IOL? Well, these days toric IOL is among the premium IOLs, is the most popular IOL and has the best outcome. We use multifocals, we use other premium IOLs, but in terms of patient satisfaction, in terms of outcome, I guess most of us will agree that the toric IOLs are a boon. They are the best things that have come up in the premium IOL group. Because 20 to 30% of patients who undergo cataract surgery have some amount of pre-existing astigmatism, which results in some visual blurring and some sort of loss of clarity in spite of having 6/6 vision. So that is the case in many of the cases, at least 1 out of 4, and that's why the toric IOL. Now, when we have to select a patient, it doesn't mean that somebody having 0.5 diopter of pre-existing astigmatism, you can select a patient. No, it's not. The patient should have a significant astigmatism and a significant primary astigmatism, which should be regular. And that should be more than or equal to 1.5 diopters to have the best satisfaction. Then regular pattern of astigmatism, as I said earlier. In keratoconus, yes, we have used these IOLs, but the patient should have minimal progression, otherwise the purpose is defeated, because the astigmatism will keep increasing and the patient will be very dissatisfied. So the keratoconus only if there is minimal or no progression. Post-keratoplasty eyes, but once the sutures have been completely removed, then patients with some other corneal pathologies like Fuchs or stromal dystrophy, they are not suitable because you don't know. The patient will have to undergo a corneal procedure later, so it's better not to implant a toric IOL at that stage. Rather, on the reverse, if you are doing a keratoplasty, any procedure, do it first, and if the cataract is not significant, do it first, and then, of course, whatever astigmatism is there, that can be taken care of. And, of course, those patients who have unstable bag, if it's a mild instability, mild zonal deficiency, I'm pretty sure Chaudhary must have put many toric IOLs in those by putting endocapsular ring and all that. But yes, if it's a significant instability, then we have to be a little cautious in using these lenses. The The toricity of the IOL is based on the corneal astigmatism, and we have to measure the corneal astigmatism accurately, and these are the instruments that are used for measuring the astigmatism. However, the keratometric astigmatism is the one that we all rely on. And Cox postulates are that they have thought of the posterior surface of the cornea also, and the toricity, if it's there in the posterior surface of cornea, then you have to decrease the corneal astigmatism by 0.5 diopters and with the rule astigmatism, and increase corneal astigmatism by 0.3 diopters, and they found that the results were quite good. Now, there are certain things. You have toric calculators of various lenses, like as Chaudhary was mentioning, AcrySof lens, you have the Technis lens, you have the Hoya lens, and all these, they have separate IOL, toric IOL calculator. Now, what all things is needed to know so that you put it in that software of toric IOL calculator? One is, of course, the spherical power that is calculated by the standard formula. Cylinder is calculated by the toric calculator, and of course, as I said, there are various toric calculators. So let's first see the AcrySof toric IOL calculator, which is of course a very popular lens, a hydrophobic acrylic lens with a good stability, a very good outcome in terms of in toric IOL group. So this calculator, this gives you the model, and the model basically means that what is the toricity of the IOL. It's, the model is based only on that. Now, what are the inputs that you have to put in? Preoperative manual keratometry, then IOL power as calculated by any IOL formula, incision location, and your own surgically induced astigmatism. These four informations you should have. Now, these four informations, you put it over there. You put your name and all that. You select the eye, then you put the flat K, the steep K, then IOL spherical power based on the IOL power calculator, whatever formula you're using, depending upon the size of the eye. Your own surgically induced astigmatism, about which I'll come a little later. And of course, incision location. Now, incision location has various degrees, like if you are in the right eye, if you are making a temporal incision, it is 180. In the left eye, if you are making a temporal incision, it is 0 degrees. And depending upon the incision site where you make, you enter the data. Now, surgically induced astigmatism is an individual's own astigmatism that is induced by the surgery. It depends on the incision size, it depends on the manipulation that you normally do, and this is the website wherein you can go and calculate your own SIA. Now, these are the things that you have to. These are the things. These are the things that you have to put it in this SIA calculator. The incision location, the incision type, size, pre-op K, pre-op A1, A2, then you have to K1, post-op A1, A2. That is the axis. Now, these data you put, and then you enter create, and then you get this surgically induced astigmatism. You keep doing it for 1,000 of patients, and then get an average of, say, okay, whatever you have. If you do a 2.2 millimeter incision, you can have something between 0.25 or 0.37, something like that. So you do it on the website and get a SIA, and then of course what is the K1, K2, you know what is the IOL power, spherical power, you know what is the SIA, and you know what is the incision location. So all these things you put it on this Toric calculator, and then you get the final model. This is the model, this is T4, this is the spherical power, this is the axis where you have to place, and of course this is the cylindrical power that is there in the IOL. So you need these 4 informations, put it in, and get the value. Now, as I said, it's just a repetition slide. Now, going into another calculator, the Hoya calculator. Now, this calculator has one advantage, that you can have an idea of the post-op astigmatism as well. So sometimes you feel that if you want to have, say, against the rule astigmatism of 0.5 after the procedure, you can manage along with that, because it is said that a little bit of against the rule astigmatism helps in presbyopic eyes. So there may be difference of opinion, but yes, this gives you the freedom of actually knowing what will be your post-op cylinder by using a particular model. There are various models available, various types of IOLs available, so I won't go into it because it's something which is a commercial aspect. But the AcrySof lenses have these powers available. The Hoya Toric lenses are these. And of course, as I mentioned earlier, the last point that I would like to mention here is that the hydrophobic acrylic material is the best material in terms of stability of IOL, because they have the best adhesiveness with the capsule. So it's always preferable to use hydrophobic acrylic when you're using a Toric IOL. Thank you for your patient listening.